Beacon Community Connections has gathered the top healthcare leaders, and they're going to share their collective wisdom and experiences and how they're dealing with COVID, what's happening on the front lines, and also how are they treating and addressing their patients for an illness that none of the textbooks prepared them for. I believe that the synergy of their voices is going to make for a compelling discussion and also dispel some misinformation that may be out in the community. I'm honored to be a part of the summit, and I feel great to be at the table with some of the best of our best. So we're going to start with session 1, which is Systems Challenges as Opportunities for Advancement. And our first guest is Dr. Amanda Logue, a graduate of LSU Medical School, and she's Chief Medical Officer for Lafayette General Health. Dr. Logue has led physicians in transitioning to a fully electronic medical system, record system, and developed an informatics team focused on improvement through the use of technology. Board certified in internal medicine and clinical informatics, Dr. Logue believes in the power of scientific research and its efficacy in providing the best treatment options for patients. Dr. Logue, will you please join me and have a seat up here? Please welcome her. And I think you can begin your 10-minute talk.
All right, thank you for having me. This is quite the pleasure, and I've been working with Beacon for a couple years, so I'm very excited to be a part of this summit this time. I'd like to first start off by thanking all of the healthcare workers that we work with every single day. This has been a tremendously trying time. None of us were ever prepared for what we're dealing with, and every single person that I know that works in healthcare, frontline workers included, have just stepped up to the plate and continue to do so every day, and we would not be here without them. I just wanted to talk a little bit about how we've had to adapt to sharing information in this time period, because it's really been unlike anything that we've had to go through before. We're very used to working off of things like protocols and evidence-based medicine and standardized treatments, things that we've relied upon for years to make good decisions and to understand what our outcomes are going to look like for our patients. That certainly doesn't mean we don't have surprises. I think any person who takes care of people will certainly let you know that they are surprised sometimes, and things are unplanned. However, we still have ways to go about getting information, doing literature research, using our colleagues and our networking to try to figure out how best to treat somebody who is not responding the way that you would have anticipated. And certainly we're all trained in things like emergency preparedness. So we're ready for things like mass casualty, mass trauma, hurricanes, environmental disasters, chemical exposures. Those things come on abruptly, but you work on triaging, you treat, then you work on recovery, and you usually have an end in sight, something that is, when that disaster has passed, you will kind of get back to normal business. The difference this time, of course, is that we're dealing with an incident command situation, a disaster that has happened with all of us learning how to treat it at the exact same time, and no end in sight in this. So that has been very challenging to go through that scenario without having a lot of experience at all. We didn't have any kind of research. We didn't have any kind of trials. We've seen respiratory illnesses before, but never in this level, and this was certainly something that was very unknown throughout the world. And we could see the pattern of treatments happening different places around the world at different times, and we were attempting to adapt to it as fast as we could whenever people were ending up in our area sick with the same disease. We were using a lot of word of mouth, which is very unusual for healthcare. We usually have a lot more things to back ourselves up on and to use for information. This was very unusual for us to have to rely on communication at the time frame that you needed it to try to take care of people for a disease that you had never seen before. And so we had to create our own in a lot of scenarios. We didn't have something that facilitated that for us. So all around the world and the country, people were spinning up their own versions of how do we share information quickly, because we needed to. The problem, one of the worst problems about this was the people that had the most information, all of it anecdotal from limited experience, but they had the best information to give us, were also the people that were still dealing with a full-on pandemic in their health systems. They were exhausted. They were still very much needed at their locations, and many of them were sick themselves. So that was a challenge in and of itself, to ask for more time to help your colleagues and help others to be able to plan for what was coming their way. It was even more challenging for them. So we had to develop some channels, and we did so locally with my other colleagues that are going to be on stage. The three of us were involved in some local organizations that we got together rather quickly, where we could get our leaders, our healthcare leaders, together on one phone call as often as we needed to, and we could take that information and then disseminate it in our facilities or our employees or wherever we needed to. We would certainly talk about things like treatment protocols and experiences, how you saw people coming to your facility. What did they look like? What kind of symptoms did they have? We certainly wanted to know about testing. When do you test? How do you test? What does it look like? How fast is the turnaround? And what kind of outcomes were you seeing? Is this something we should try, or don't even bother because it's not working? One of the interesting things we had to talk about, which we don't usually have to, is personal protective equipment. That's usually a supply thing that's generally fine in a situation. But in this particular situation, as you know, we were desperate, and there was a lot of concern about having the supply when we were going to need it at the worst time. I remember one phone call that we had, one of these physician local leader phone calls with Dr. Burnell was telling us about pathways that he was able to find extra PPE through Amazon if we were to go on and notify Amazon that we were a healthcare facility in need. We could get additional supplies. And that's the kind of stuff that we ended up having to talk about on these. And we would walk away from those phone calls. We would then go to our own local networks, share that information, and then do it all over again as often as we needed to in order to try to get the right information out. Also, we were trying to help guide the national and local leaders. They were looking to us for answers, and we didn't always have those things. And so that was very hard at the same time, understanding that typically we can give really good information about what we're seeing, if there's a rise in something like cancer or hypertension. You know, we have some data behind that. But in this scenario, we really didn't have a lot of answers, although we tried to give the best information we could. We also spent, I can speak for the group of us that's up here, that we spent a lot of time handling misinformation and bad communication that was out there. We had to constantly be educating our friends and our family, sometimes the leaders, our patients, our colleagues, on what was the right information to go by and what wasn't. And personally, I can say I wasn't always sure that was the right information. I was going off of the very best information I had, but given that this was unfolding as we were going through it, it was very difficult to know for sure if this was going to be the right thing to say. So I think ultimately, I know that we were not the only group to do something like this. I know this was happening all around the world. And I know that because physicians that I work with were also using their channels at other communities that were feeling the same amount of COVID patients and dealing with that. But I do think that it really shined a light on the fact that we don't have great processes within healthcare to share information that rapidly. Eventually, a lot of national networks and global networks of physicians and nurses and all of the healthcare worker communities ended up kind of getting into place and getting their information out quickly. But it could have probably been done a little bit sooner. Very similar to a way a hospital will jump in with an incident command system when they have an emergency situation. You get all the people around the table, you share the same information, everybody hears the same thing, and you have the opportunity to ask questions and clarify. In addition to being agile and sharing information like that quickly, I also found I still find interesting the way in which research is being handled. So, typically the common public doesn't really is not truly aware about, more than 350,000 clinical trials are ongoing worldwide every single day. That's just something that has been happening over decades, and honing that process, and they're not truly aware of it. The majority are not, and that's fine. They're also not. The majority of the public is also not really clear about the stages of research, the phases that we have to go through, and the oversight and the safety and efficacy that's in place for us to develop a good protocol. What happens in a really well done study is that you end up with trusted data, you end up with peer-reviewed data, and you end up with information that you can take back and use for decision-making on your patients. In this particular scenario with COVID, we've had to go through the scrutiny of how research is conducted at the same time that we need the research to be conducted. And I'm not saying there's not opportunities for improvement in clinical trials, but there also is a lot of misunderstanding out there. And so what I'm worried about is that with that misunderstanding, there has been some mistrust in the processes, which ultimately may lead us to not being able to use that data on patients as well as we would like.
Dr. Logue, thank you so much. I've got so many questions I'm already thinking of. We're going to have all of our speakers give their presentations before we start more discussion. Our next guest is Dr. Charles Burnell. He's Chief Medical Officer of Acadian Ambulance. Dr. Burnell is a graduate of LSU School of Medicine and is board certified by the American Board of Emergency Medicine. He serves as lead over other associate medical directors across Acadian service areas. And I know from experience that Dr. Burnell's heart leads him to protect his employees as they suit up every day to provide emergency services. And you can't think of anybody that's more on the front lines than Dr. Burnell in Acadian Ambulance. Thank you so much for joining us.
Thank you for that warm welcome. Well, I've got a little presentation here that I'm going to just give a few slides. And one of the, Dr. Logue did a wonderful job of outlaying a lot of the challenges that we're dealing with from a medical standpoint. And let me see here. Let me just get this first slide up. There we go. Okay. One of the things that was interesting and still continues to be about this event is how to get accurate information out to a remote workforce or even the community as quickly as possible. As we watch this disease process progress from overseas, and Dr. Logue and I were talking about this earlier, it was kind of like we were a little bit insulated from what really was happening just because of the Atlantic Ocean between us. But as this thing progressed into here, it became real very, very quickly. And hitting the road, running, and trying to figure this thing out with very limited information, and also a lot of misinformation out there was a big challenge. And one of the things, as a healthcare provider in a company that has the responsibility of caring for communities, getting good, accurate information to take care of those that we serve, those patients that we take care of, and also to protect our workforce were two of the very big focuses early on in this, and continue to be two of the large focuses that we had to really prioritize. One of the things that I did, and it became apparent very, very quickly because of the media and a lot of things that were going on, that we really had a need to get accurate information, to get that information out quickly. And if we didn't, then people would fill those, what I call information vacuums or gaps, with whatever they could find on the news media, on social media, or anywhere like that. And there was a lot of rumor, and there was a lot of fear, and there was just a lot of disruptive information out there that prevented us from doing our job. And Dr. Logue had mentioned the PPE, personal protective equipment. You know, what is the right equipment to use? Who do we need to use it on? How do we need to test? We knew that we were going with our first responders and paramedics and whatnot, going into areas where these are known COVID patients. There was no way to avoid that. Like Dr. Logue's team and Dr. Kaufman's team, that's our job, that's what we do. But how do we do that safely? Because we knew that decimating our workforce and having the inability to care for those communities was not an option. So some of the big things that we did, we started trying to do the memo thing like we're traditionally doing, and that just did not work well. People were coming to me and the other leaders in the organization. You think this is true? Do you think that is true? I mean, what do you think about what I saw on CNN last night? What do you think about, my brother-in-law sent this to me on social media, and we just got inundated with questions. And it's hard enough to go through and try to figure out the medical research data and all the social media data and all the news data, and especially when you have a lot of that conflicted, and you never know where that's coming from. So one of the things that I did, and I'll talk a little bit about opportunities, this communication channels, I had opted to go ahead and just, I started off trying to do some videos, and I did for probably the first almost 2 months, I did daily videos, 7 days a week, with our employees. And of course, you spend a lot of time going through the data because you want to make sure that what you're presenting is accurate. So spend a lot of time just researching, going through things to make sure that those employees that we need to empower with information have the right information. And I started off with a fancy video camera, and that was just these things a lot of times are spontaneous. As you know, this pandemic has been spontaneous, and when we go through information on a very rapid, changing basis, you have to be able to adapt to that very quickly. Doing little videos and whatnot with this was really a godsend to me, to be able to be that source of information, to be that accurate source of information, and to disseminate that quickly. Video technology, like I said, we started out with fancy stuff. Eventually, it was an iPhone that I had come to, and I even got a lot of feedback say, it seems more genuine, it's not as polished, it's more real, I guess you would say, kind of Jay Cantori-ish out there in the storm, and they could see me, they could, visualize me. But that video technology, very quick, very easy to disseminate. Trying to keep the cost down on this, trying to keep the information accurate, and, the written word, people don't check emails like they should. We have an internal intranet. People have, the regular internet. They have social media, and try to consolidate that into one thing. I could do it very, very quickly by video, and I could snap a message out very quickly. It was not as polished. The lighting might not have been as great as we have in here. But that was, and the other thing with our workforce, we have workers that actually in almost 30 states. We principally are in 4 states, but trying to, in 5,000 employees, trying to get those employees looking at one source and getting the right message every time is a challenge. But the other thing is when you're looking at distribution of these materials, it has to be very accessible, and this is what people communicate with nowadays. This is the message that they get. But what I've done is, and to wrap up, is I've been able to keep these employees engaged, become their single source of accurate information. And I even hear a lot of them, and it's a compliment to me that they would say, well, I saw this and this and this, but Dr. Burnell said this. So then I became that credible, verifiable source of information, and that was the eventual goal, was to make sure these people were armed with the information, because as a healthcare provider, any of you that are in healthcare, I would not doubt that countless people come to you to ask advice, to ask opinion, to ask for help, and you become that resource. Everybody has a, quote, nurse or a paramedic or a doctor in their family that they lean on hard to get accurate information, and there's a responsibility that goes with that. None of us want to miscommunicate. So the ease of that transfer of information, the responsibility of getting it down, for me, the video was the way to do it for the remote workforce, for large numbers of people. And it really, those messages are easy to go back to and refer to, and I would keep those things very, very short. My attempt was 2 minutes, but those of you that know me, I'm actually pretty shy once you get to know me. But that was a joke. But sometimes I can be a little verbose. But 2 minutes to me was a challenge, but that is about the attention span of most people with a video. Some of my videos went a little bit longer if we had a lot of topics, but the intent was to make it quickly accessible, easily transferable, easy to repeat the view and go through, and really easy to disseminate. So the iPhone was my choice, and it was really nothing fancy, but it worked very well for us. So I'll entertain any questions. There's a lot more I could talk about, but I will keep on track here for the sake of time.
And you know, Dr. Burnell, as a consumer of healthcare, I think most of us, we just want to get treated. We're not really thinking about the people treating us. You know, that you've got to stay healthy so that we can get healthy. And so I'm really enjoying the behind-the-scenes look at what everybody's been going through. And we're going to ask one of your colleagues to join us. Dr. Henry Kaufman IV is Chief Medical Officer of Our Lady of Lourdes. A native of Abbeville, Dr. Kaufman graduated from LSU School of Medicine. He specializes in surgical oncology and is board certified in general surgery. And as an aside, I know that you became known in the media along with Dr. Logue for your video and also a letter that was never intended to get out into the public, where he was imploring people to listen to the healthcare experts, wash our hands, wear our mask, and adhere to social distancing measures. So Dr. Kaufman, thank you for joining us this morning.
Thank you. I think Amanda and Chuck did a great job of laying out exactly what we were going through at the time from the perspective of, you know, how do we pivot toward caring for an entirely new disease? How do we pivot an organization and fighting disinformation and getting information out? Perhaps the best information I can give you this morning is perspective on how this was affecting the hospitals internally and our decision-making process as all this was going through. So to kind of jump back on the timeline, the first case of COVID-19 illness was in December in China, and it was around the first of the year the World Health Organization started getting involved, and about halfway through the month of January that they actually declared a World Health issue. We then start seeing cases in Italy. Italy's got a fairly similar population to the United States in regards to longevity, our healthcare systems, and we're seeing dramatic spikes in cases. They're experiencing death rate of 14 to 15%, and that put the entire world on notice. It was shortly after that that we had our first cases in the United States, and before too long, the first cases in Louisiana. And within really 9 or 10 days of the first case in Louisiana was when Governor John Bel Edwards declared an emergency, shut down schools, and within a week or week and a half of that is when we shut down all elective surgeries. And that has had the most dramatic and profound effect on the hospital's day-to-day operations of anything. It was a reasonable and sound thing to do at the time. You know, we're seeing dramatic uptick in cases in New York, in New Jersey. New York hospitals are getting overwhelmed. We're seeing a similar pattern that we saw in Italy. We're seeing a geometric increase in cases locally, and we're looking and hoping and waiting it's not going to hit that logarithmic curve that it did in some places in New York and certainly did in Italy. We're also looking at a potential death rate of 14 or 15%, which is just dramatic and profound. And even as bad as New York was, overall their mortality rate in the height of the pandemic may have reached 5%. So they were in a crisis, their hospitals were overwhelmed, and we've learned in retrospect that the mortality rate in Italy and the higher mortality rate that we experienced in New York was probably a consequence of the healthcare systems being overwhelmed. So as we're learning that, our first goal in the management of the disease is not to overwhelm the healthcare systems. And that's a point that I think we've done our best on a national level and a local level, healthcare experts, to drive home. The curious thing about when we shut down elective surgeries was how quiet the hospitals were. And even though a quarter of our hospital capacity locally, and maybe a little bit more across town at Lafayette General, was occupied by COVID patients, because we weren't doing elective surgeries, because of the fear in the community and the public of going to the the hospitals were I don't want to say empty, but they were very quiet. The surgical floors were basically clear. The medicine floors, we were missing a third of our strokes. We were missing a third of our heart attacks. We were missing a third or more of our new cancer diagnoses. And we were seeing a mortality in the public from our public health officers go up, maybe not related to COVID because people were scared of coming into the hospital. Now, if you're facing a mortality rate of 10 or 15% or maybe even 5%, that's a very reasonable thing to do because we're looking at the resources that we're going to need down the road to deal with a crisis. Fortunately, that first wave abated without that logarithmic growth phase that we were all worried about, and the hospitals by that point had stocked significant PPE. We had started developing better ways of disseminating information, better ways of taking care of the disease, and a higher level of comfort of dealing with the disease. And that was one of our biggest challenges in the midst of all this as a medical community in how to respond to it, because you want to have a rational response, but you also want to have a healthy fear of the disease. Part of our biggest challenge in addressing the disease and how we're going to care for not only our team members but also our healthcare providers was how to mitigate against that irrational fear. And one thing that became obvious was the further that one was directly removed from patient care, the more irrational the fear of dealing with the disease was. The people who were dealing with it from day one, our EMTs, our ER doctors, the internists, the nurses on the floor, the ICU, they very quickly became comfortable. Now, they maintained a healthy level of fear and were good about their PPE and they were protected. And what we began to learn is, after weeks and weeks and ultimately months of exposure to this disease on a daily basis, is if we were just smart about this thing, if we wore masks, if we washed our hands, if we were careful with how we donned and doffed our PPE, we didn't get sick. And the fear, the irrational fear abated, and then you have a little bit of trouble with perhaps loosening or getting lax. And there were a few cases of individuals getting sick within the hospital. And when I say individuals, I mean team members. But we can almost always trace that to some known event or break in the PPE process. For example, someone has a respiratory crisis in the ER and an emergency room physician rushes in, is charting on his chart. He's taking his mask off to grab a sip of water. Patient codes. He rushes in, not thinking to put his mask on, intubates the patient. Patient comes back with COVID. ER doc ends up getting sick. And it just takes some time to have all those things ingrained in us. The further we've gone in this pandemic, the better our comfort level, the better we've been able to manage that rational approach to the disease. And that has certainly smoothed operations, and we maintain a healthy respect for the disease. But on the same hand, we've figured out how to work within it. So the first wave passes. We get better at dealing with the disease. I think we were all leery of this coming second wave that we were all fearing, but had an enhanced comfort level in how we were going to deal with it. Again, we don't know where the growth is going. Again, we start seeing geometric growth, and we very rapidly surpass that 25% capacity number that we experienced initially in the hospital, and then we get to a 50% capacity in the hospital and then eclipse that 50% number. That, fortunately, that peak came right about the time as the governor put the statewide mask mandate in effect, and what we all saw was an immediate decrease in the number of cases and the local transmission of the disease. And we've got naysayers even in the medical community in regards to masking, and it's become a very hot topic. The clear evidence amongst multiple communities that have put masking effects in is that as soon as the masking goes into place and social distancing, that you do see a decrease in the number of cases. So at that time, even though we were dealing with over threefold the number of cases that we had during the initial pandemic, our comfort level and our plans that we all had in place mitigated against negative effects and enhanced our ability to take care of those patients. By that time, the restrictions on elective surgeries were not put in place. And in fact, the Louisiana Department of Hospitals left it up to the local facilities to manage their operations. And what that allowed us to do was to continue to take care of elective or urgent cases while not putting off and not getting into as profound of an ethical dilemma of just shutting down surgery completely. Because when we say elective cases, we're not talking about plastic surgery or cosmetic surgery. We're talking about knee joints that affect people's mobility. If you can't walk, your health deteriorates. We're talking about people with spine injuries that may not have a neurological deficit, meaning they may not have muscle weakness, but they have severe pain. We're even talking about early stage breast cancer, early stage colon cancer, and other things. And that's a little bit shocking, but we've got really great data in the cancer community, for example, that an early stage breast cancer, as long as we initiate some form of treatment or therapy within 12 weeks, there's no change in their outcome. And we know that because people come into the ER all the time with heart attacks, strokes, et cetera, and we can't direct our attention to the breast cancer. That gets put aside, we recover the patient from their bigger health event, and then we address their breast cancer. And the reason that's the case is because likely in breast cancer that the treatments are so effective, it doesn't matter if we wait 3 months. And in fact, in a lot of circumstances, we can probably extend it beyond that. But imagine telling a breast cancer patient, I'm very sorry about your diagnosis. You appear to have a relatively early stage breast cancer, but we can't operate on you right now, and we're going to have to put your surgery off. And I don't know how long that's going to be. Let's get you in to see the medical oncologist and perhaps get you on a hormone blocking pill to slow the progression of the disease. But we're going to call you every week and let you know where we are and let you know where the plan is. So we had a lot of phone calls and working patients through it. When we hit the height of the pandemic in the hospitals, and that was over 50% capacity at Lourdes, we had to restrict surgeries to nobody was allowed to do inpatient surgery that required a bed. So any surgeries where the patient could come into the surgical platform, be operated on, and get home was allowed to proceed because we didn't have beds in the hospital. And not only were our beds full, but probably a bigger issue across the community was we were having team members get sick from community spread. And so we just didn't have the nurses and techs and staff that we needed to take care of these people. And so, barring an obvious emergency that would come in that needed surgical intervention, every case that proceeded on a daily basis was a conversation between several individuals in regards to the severity of the case, what our ability to take care of that patient in the hospital was, and what our bed availability was. And so my surgical, the surgeons as an independent physician, you are responsible for being an advocate for your patient. So my surgeons were having to advocate for their patients and coming to us and saying, we need to operate. And I had to advocate for the hospital and the community, and then we had to come to some negotiation. All those conversations were very cordial and remarkably understanding, and we were able to work through it. Fortunately, the numbers with the mask mandate came down, and we slowly opened up surgery to the point where now, for the last 4 or 5 weeks, we've had unrestricted access to the operating rooms, and we're able to maintain our bed availability. You can imagine there's a substantial backlog of cases, but again, our colleagues have been very reasonable in not overtaxing our already taxed operating room staff. So one of the biggest take-home points, at least from a healthcare system standpoint and trying to run multiple ORs and multiple platforms and preserve resources, is resources are best managed at the local level. And the state and their mandates gave us breathing room, but once we all realized where we were and what the resources would be, local control was the key to optimizing the amount of care that we could provide while still trying to get the community through the pandemic.
Dr. Kaufman, as you were speaking, thank you so much. You've each shared a different perspective on what's going on, and I don't know about our audience, but I envision us as soldiers. the individuals in the community, we have to suit up and we have to arm ourselves. And the only thing we can do is listen to you guys. And it must be insulting to have people question medical wisdom and experience. You know, when you've either got people that are very skittish about going out in public and won't go out, or people blatantly flaunting the requirements of wearing a mask that the governor, I think, has judiciously, called upon us to do. As you've each listened to each other, do you feel that you've gone from being possible competitors to true collaborators in moving forward? Is that what's happening with our healthcare? Not that you want to look at yourselves as competitors, but hospitals are profit-making arms of our community. But Dr. Logue, was there something that struck you as your two co-panelists were speaking about what you've learned in the last 6 months, where you are now as compared to March?
Yeah. Well, I mean, we went through this together, and three of us plus everybody else that we collaborated with, educated. We grew up in this pandemic together. So, competitors are not in a market. That's going to exist no matter what. But when it comes down to what are we going to do to save our community, what can we do to educate people, there's competition is out the window. I mean, we have to be united in that, or one of us will fail, or all of us will fail, because if we're not sharing the same message to the best information that we have, we both are needed in this. We're all needed in this community to take care of the amount of patients that are here. So all of that goes away, and you just get down to business and share the best information you can. And we're all coming from the same background of medical training, and we work with all the same types of people, and we're all seeing the same thing. So I think we come at it from that perspective.
I'm curious, before I move to Dr. Burnell, do you have a stockpile of ventilators now? Like, did you buy up things at the beginning of the process and realize that wasn't the most effective as you gained
certainly.
experience?
As I spoke about, we did the best we can with the best information we had, and then we learned along the way. And we had a little dip there, as Dr. Kaufman was mentioning, where things eased up and we had some time to breathe and reflect and hone our processes, and continuing to learn from the rest of the world so that we could say, well, we've all realized that doesn't work as well, and maybe we don't need those anymore. So yeah, we have some extra stuff laying around that we don't need anymore, but as I said before, this is not over, and none of us are naive to think that we may not need it again. And so, we put that away, hold it for the next time something comes up, and we'll be ready.
Yeah. Dr. Burnell, I know that numbers were down, as everybody was saying, people wanting to go to the hospital. Are things equalizing now? And maybe y'all can talk among yourselves, but I know for a while nobody felt it was safe to go to the hospital.
Yeah, so I think one of the gauges that we used when we worked together through this situation was, what do your volumes look like? That was a big question on a lot of the meetings that we had weekly. And yes, our volumes dropped substantially, which creates a whole nother staffing issue. You're overstaffed and you don't have the volumes to really support all those people out there on the street, but you also have a duty to be able to respond. So we probably had a 30 to 40% decrease, which lasted for a long time. That has since recovered somewhat with time. We're not back to where we were pre-COVID, but I'll say that we've adjusted our staffing models just like the hospitals have to do. It was an all-hands-on-deck affair for a good while there, and we've gotten to take a little bit of a breath. But you mentioned the competitive thing. I never sensed any competition. I think that adversity either drives people together or it drives them apart. And this community that we live in is a very cohesive medical community. And honestly, we would lend any information. There was no thought of competition. It was just try to care for the community as best we could. And if you can imagine people asking, what's it like trying to drive this information thing and make sure everybody's protected? Well, if imagine yourself being a school bus driver with a load of kids behind you, and one of the kids gets very ill, and you're driving through thick fog in an area that's very unfamiliar to you, and you're trying to navigate this thing without harming everybody on the bus, but having another set of eyes to say, watch, there's a stop sign coming up, or there's fixing to be a turn in the road, or whatever, because That's really what you're doing. We're going into a fog here without really knowing all the answers and trying to navigate this bus down a pathway where everybody's safe in the end and we get our emergency taken care of, and that's kind of having these guys to shoulder a lot of the decision, a lot of the information. And look, we all review information on our own independently, and we all have access to different resources. I have an international resource that I met with weekly, a group of BMS physicians across the globe, that as this thing transpired from across the pond, from Far East to Europe and then to the US, we had real-time data from these guys overseas that we were, initially twice a week and down to once a week. We knew what to expect in advance, and that was easy to share within our community here. And it saved a lot of time sifting through all the stories on the media, and the unavailability of good research information, or even good anecdotal experience was one of the difficult things. But from a competitive standpoint, I really think the working together, the pandemic and the stress of all that adversity absolutely drove the healthcare providers in this community 100% into one common force. And we leveraged all that, I think, to try to make sure that this community was as protected. These people are our families, our friends, that they're as protected as they ever could be, regardless of where they are in the United States of America.
Dr. Kaufman, I'm not sure people realize how quickly you've pivoted in your role as a surgical oncologist. You were serving as interim chief medical officer. Our conversation we had in preparing for this, when I called him, he was actually about to walk into surgery. You're still actively practicing, and you were learning on the job not only about the pandemic, but you're an administrator now. So you're having to shift your focus from purely patient, I'm going to argue for my patient, as you said, to looking to the bigger picture. You seem calm, and when we spoke, I thought, he's walking into surgery, and you took time to visit. Would you share some of that? I mean, you've had to look at the hospital's bottom line. All of you are experiencing decrease in other revenue streams, and you've had to walk into a thicket.
Sure. So, shortly after the school closing statewide went into effect, it was clear that there was going to be a change, and there was a notice that a memo was circulating that they were going to be shutting down elective surgeries, which was done in other communities in other parts of the world and seemed like the reasonable thing to do. There had been a change in leadership at Lourdes, and there was no active CMO. And I knew the chief of staff there very well, and they were getting very busy, and it seemed like I was shortly going to be not as busy. And so I just casually mentioned that I was in a position to help from an administrative standpoint if I could share any of the burden that they need in regards to medical decision-making on the surgical platform, because I'd served as chief of staff for about a 4-year period when the hospital was built and then transitioned in the new campus. And part of that was developing a whole new sets of bylaws and rules and regulations, and so I was fairly familiar with all that. To my surprise, and definitely it was not my intent, was the way that I was told that I could best help the hospital was become an interim chief medical officer. And certainly by that time, the surgical volume was down. I was probably about half as busy as I was previously, and it seemed like a reasonable thing to do. But more importantly, I didn't feel like I could just sit on the sidelines while it was kind of evolved around me. Once I accepted that role, and then the information pathways that had been put into place, and the meetings and the phone calls, and then also everything coming from the FMOH system, it was literally like drinking from a fire hose. And I'm an information junkie, and I was like a kid in a candy store. But like Amanda alluded to, a lot of bad information as well. Mm-hmm. And when you don't have time for formal studies and peer review and published articles, then you're trying to take as much anecdotal information from as many sources, try and filter out the junk, and then try and glean some nuggets from that information and try and predict what's going to happen and where you're going to be and what you're going to do. So that was a fascinating time. It was a very different role for me in regards to at least my day-to-day operations. And Amanda and Chuck and our fellow CMOs in the community were great about dragging me along and helping me out. I think we shared not only resources, but protocols and policies and procedures and, how are you guys doing this? And we're doing that. Hey, let me get you this protocol we came up with. And that was a huge time saver and efficiency thing that if one individual, for example, had developed a protocol for how we're going to do with surgery during COVID, then that individual could share that across multiple hospitals and all the CMOs in the region, then we could use that moving forward. So yeah, there was a great cooperative atmosphere amongst all the physicians in the community and also all the institutions, not only with information but with resources, and that was
Right.
really, really, really nice to see.
So I guess you all agree that we should be wearing our mask all the time. There's no doubt. Now, Dr. Logue, you mentioned that, Lafayette General is about to undertake a vaccine trial. Are you able to discuss that with us?
Yeah. Along the lines of research, I'm excited that with our partnership with Ochsner, it looks like we'll be initiating a vaccine trial for COVID here in Lafayette in about 4 weeks. We have a lot of details to work through between now and then. Most exciting thing about this one in particular so far is that it's a single dose as opposed to the 2 doses that are needed for all the other trials. So hoping that will attract some interest. We're looking for a diverse population of people so that we can make sure that as we've seen COVID proportionally affect different types of patients, we want to make sure that all of those patients are well represented in a trial so that when this is a phase 3 trial, when it's all concluded and able, if it's successful and able to go to market, that you can honestly step back and say we had a very diverse population that got it, and you can feel good about the outcomes that you see in each one of those so that we can better protect all of the members of our community. So yeah, we'll have more information coming out in the next few weeks about how to enroll, and there will be a lot of media announcements about that at that time.
So I've heard, on the news, of course, President Trump saying that a vaccine can be rolled out pretty quickly, but that's not typically how it works, right?
It's not typically how it works, and that goes back to the discussions around the phases, phase 1, 2, and 3. And there's a number of things that happen in those phases, and there's check marks along the way that are very necessary to say, are you producing something that is safe and efficacious along the way? Are you representing the right group of people? Are you biased? Do you have any bias in your research that would make the outcomes look better than they should be? And those stages are, there is some things under the federal government right now that are trying to facilitate those to go faster. But when it comes down to it, a phase 3 trial, for instance, needs to have the largest population of patients that you can get with the most diversity, depending on the type of research trial you're doing. In this case, the largest group that you can get means the best data that you can come away with, saying we tested, and this trial is looking to test 60,000 people globally.
Oh,
they enrolled their first patient on Monday. So it's underway globally, but when you walk away with 60,000 people in a trial and you're able to say, less than 0.001% of people of all types that joined this, male, female, and all races, had a significant side effect. You have a lot more substantial information to go on, and the public and the healthcare workers can feel good about standing behind that information.
Okay. We've got about 10 minutes left with this panel. I'd like y'all to talk among yourselves about what you see coming up this fall. Are we in winter? Are we going to experience an uptick? You know how the flu season always seems to get worse as it gets cold. I don't know who wants to jump in, but what are you anticipating?
Dr. Logue and I had talked about this earlier, and I think that one of the fears that we have is a dual pandemic, with influenza being part of that and COVID being the other part of that. We know from our friends down in the southern hemisphere in Australia that the COVID PPE in place for all the COVID that they're dealing with down there has greatly diminished the amount of influenza that they're seeing down there. And, a lot of the comparative comments that we get from this, people, that I get from different people say, well, this thing is no worse than the flu. If you look at the numbers from the flu, well, if you think about the numbers from the flu, is people don't wear masks, they don't do proper hand washing, they're pretty much just out there doing what they want to do, traveling where they want to travel with no inhibition. And that was the numbers for the flu. When you look at COVID, which has been just largely protected with PPE, with rigid policy and whatnot in place, and yeah, it's not quite as bad as the flu, but watch what happens with the flu. I think the flu, if it holds true to form what's happened in Australia, I think the numbers in the United States, because of all the COVID protections in place, are going to significantly diminish. We always, every year, wonder, is the flu vaccine going to work or not? Well, this year is not a great test year because there's going to be so much PPE out there that we won't really, it's not a fair comparison to previous years, But that real fear of having a dual pandemic, and I think all of us would echo that, is really the big question. And I think if we maintain the vigilance that we started with this thing, I think we'll get through the winter and the influenza pandemic okay. And all of us, when we take our Hippocratic oath to practice medicine, the big thing that we focus on is to do no harm. And throughout this entire event, that is the question that rings loud in all of our heads multiple times a day is what we're doing the right thing for our patients. And, like I said, it's a little bit like driving in a fog and really not knowing what's ahead. But by the same token, I personalize that a lot to say, is this what I would do for my own family, for my own children, for my own mother and father? And if this decision is okay, because we talk a lot about research and we talk a lot in the healthcare world about risk versus benefit. And when we look at these things, some of these decisions are not just 99% versus 1. Some of these are 49-51 decisions that we're making, but we have to make those decisions. We also have to be able to put it in reverse very quickly should we make a wrong decision, because that do no harm, that is a constant, priority to us. So, but yeah, that is a fear I think all of us share is a dual pandemic, and it is a reality if we're not careful. But I think vigilance will get us through this next tough section. Hopefully we can move forward.
I think what's going to be interesting about this flu season is that there's a lot of overlap in symptoms. Not a lot, but there are definitely similar symptoms, the myalgias and the fever and things like that. And, we're still struggling to have rapid testing that's reliable everywhere we need it. I mean, if it were a perfect world, we would have it in all the schools, right where you need it, point of care, be able to give you a rapid decision. That's just not the case. We're all still working on getting it wherever we need it at the right time. So if you can't tell the difference between whether you might have COVID or you might have flu, it would be, in years past, it would be great to think that when people have the flu, they truly isolate themselves so that they don't spread it. But we know that's not reality. But this year, people are worried enough about COVID that if there's a question about which one might I have, I think there's not only, in addition to, as Chuck said, all the PPE we wear all the time, but more isolation while you try to figure out what is it, and maybe wait on test results. That may mitigate the spread of it as well. I'm optimistic, hopeful, certainly, and I think when you talk about schools where those kids spread the flu a lot too, they will have to do that because they're not going to know the results of that COVID testing or that flu testing that rapidly sometimes.
Right.
Predictive modeling and epidemiology have been really critical tools in how we're managing this and how we're predicting things in the future. Some of the best predictive models have come from Osterholm in Minnesota at the Epidemiology and Viral Center there. And the scenario that we've seen here in Louisiana and in other places has been fairly accurately predicted. And one unfortunately likely scenario is of a third wave this winter. Every winter we get into in the hospitals what we call the respiratory season or the fall flu season. And it's not only the flu, it's other respiratory illnesses. It's when our elderly populations come in with their pneumonias. And during that, at least locally here, November, December, January season, the hospitals are basically full even in non-COVID pandemic years. And resources and resource utilization become issues, and the ICUs get full. For a healthy hospital in the United States is currently running a 3% margin. That doesn't leave a whole lot of room for a huge amount of additional resources. We don't have 50 extra ICU beds. We now may have 50 extra ventilators. But, you know, the scenario that we're in right now has been discussed for a long time, not necessarily for a novel virus, but if we get a really bad influenza strain one year, where we are right now with COVID and maybe in a much worse place was a very real phenomenon that a lot of people were worried about. Chuck is right on with the enhanced PPE and enhanced awareness of illness. There's been a dramatic decrease in the flu season in the Southern Hemisphere, both in the East and the West. I hope and I pray that that's going to be the case here, but I think that COVID fatigue is a very real thing, and this is the time where we need to maintain our awareness and our health and to keep doing what we're doing until hopefully we can get some successful vaccines in place. Once we get a vaccine in place, it's not going to be automatic. We can't let down our guard. It's going to take a tremendous amount of resources to get these vaccines out and distributed to the population to an extent where we can all be safe and get back to some semblance of normal again. So we definitely need to encourage the community. We're still at risk. The risk is very real, and it's not time to let our guard down just yet.
As we close, is there any thought that you'd each like to share that you thought I might be asking about? Is there anything that you didn't share that popped into your head? We each have about a minute maybe to close.
I mean, I think that we still have a long ways to go. I think that we typically, after you have an incident that you're going through, a natural disaster or something, you have sort of a debriefing afterwards and figure out what could we have done better. What do we want to learn for the next time we have to initiate something like that? I think that that's going to happen in terms of a national spectrum of healthcare. It's happening already in terms of what should we be doing differently, how should we be considering how we handle situations like this, how do we share information faster, how do we make sure that we have the right people giving the guidance out there and not filtering through misinformation. So I think that I'm very interested to watch the behavioral changes, the pressures that are going to be put upon healthcare systems and the way that we've traditionally done things, and certainly open to conversations about what is the right way to do it. I'm certainly not up here to say that we've got it all figured out. And I think this has shone a light on some of that. And so I'm interested to see how we innovate coming out of this.
Thank you.
Dr. Kaufman and Dr. Logue had alluded to the fact that this vaccine, as we know, is not necessarily a panacea or a cure-all. And I think it's important from a community-focused standpoint to realize that this is not like we're going to switch a switch and things will be okay. I think just good, solid PPE and hygiene and those types of things are still core to everything we're doing. Probably the face mask is one of the most important things that we have to maintain. But even with a good flu vaccine on a good year, we're only looking at 50 to maybe 60% effectiveness of that. So if you think that the COVID vaccine, with the rapid process that it's gone through for approval, the main thing was we want to make sure it's safety. But the next thing is effectiveness, and we really don't know how that's going to pan out yet. And there's been a lot of focus on the media where people are, the vaccine is almost here, the vaccine is almost here. It's not like we're just going to switch this big switch on and everything's going to be okay. The effectiveness of the vaccine is one thing, the distribution of that is another thing, and plus the reality that the true effectiveness, even if it's a successful vaccine, might only be 50%. So I tell my employees, don't take your foot off the gas pedal. Maintain vigilance And, we really need to focus on the long game here. And I know everybody's COVID weary, myself included.
Right.
But this is really a long endurance race. It's not a sprint. And I wouldn't, little glimpses of hope are nice to look at, but I still think good core principles like we've been doing are really going to keep our communities safe.
Right.
Yeah, no, to echo what Chuck said, it's very possible, if not likely, that the best we're going to get out of a COVID vaccine is going to be a reduction in the severity of the disease and a reduction in the mortality. That means it's not going to keep you from getting the disease, and it's not going to keep you from getting sick, but it may lower your likelihood of succumbing or dying of the disease, and it may lower your likelihood of being hospitalized as a result. That's going to change things, and it is going to reduce the severity, but that's not going to be the effect in everybody. We know from the influenza vaccine, it's not 100% effective. It certainly lowers your likelihood of having a severe illness. It lowers your likelihood of succumbing to disease, especially if you're older and have other comorbidities. But people still get the flu. I get the vaccine every year. I've had mild cases of the flu. And that's one of the recurring things that I get asked all the time by nurses and other team members is, do you get the flu vaccine? And if so, why should I get it? And the reason is because the flu vaccine morphs and changes every year. And I tell them what I'm doing is I'm building up a bank of immunity against the future. The same thing may be the case with COVID in that it's not going to be 100% effective. It's not going to keep you from getting COVID, but it's going to limit your need to access healthcare resources like the hospital, or maybe even, you can just take care of yourself with a little bit of, over-the-counter meds at home and not have to go into your primary care doctor, and also not be more likely to spread it and need other hospital resources. So, Chuck is absolutely 100% online on that, and that's something that we all need to be aware of.
I want to thank all of our panelists. I feel better now hearing behind the scenes what's going on, and you each bring such a trustworthy, just down-home message about what you're doing to take care of us. So would you please join me in thanking all of our esteemed panelists, Dr. Amanda Logue, Dr. Chuck Burnell, and Dr. Henry Kaufman.
Thank you.
Thank you.